Khurshid?
I'm ready. আতিক ভাই আপনাকে শুনতে পাচ্ছি না আমরা সবাই। I think we can start now.
একটা সেকেন্ড। আচ্ছা, আমাকে কি এখন শোনা যাচ্ছে?
শোনা যাচ্ছে।
এখন শোনা যাচ্ছে।
হ্যালো?
জি শোনা যাচ্ছে।
আপনাকে শোনা যাচ্ছে, দেখা যাচ্ছে।
Assalamu alaikum. We are inviting everyone to today's conference of management of chronic pancreatitis, a multidisciplinary approach. I would like to first thank Dr. Khurshid Alam Mojumdar, who is a clinical assistant professor of Northeast Ohio Medical University Center. He's a well-known gastroenterologist, interventional gastroenterology. He does as well in St. Vincent Charity Medical Hospital Center. Also, we have Dr. Saifuddin, Assistant Professor, Department of Hepatobiliary Surgery, Pancreas and Liver Transplant Surgery in Bangabandhu Sheikh Mujib Medical University. He's well known and decided to join today. He is always a regular supporter of our program. Also, I would like to invite Dr. Hashim Rabbi, my younger brother, Associate Professor, Department of Hepatobiliary and Pancreatic Surgery, eminent national and international surgeon, always there with us, and it's my privilege to work with him. So I think without any delay, I would like to invite Khurshid to take over and do the meeting.
Thank you, Atik bhai. My pleasure to be here. And first of all, I live in Cleveland. So I want to share with you, there are some breakthrough in many areas of medicine. First time human-to-human blood transfusion in 1906 in Cleveland. First time heart defibrillation, CPR, all actually started in Cleveland and some other also. So that's my city. I live in Cleveland, Ohio. Okay, so without further delay, we'll start with the case first. So this patient is actually was taken care by our world famous surgeon, Dr. Saif, and actually he's my very close relative as well. So he's a 24-year-old male with no significant past medical history, multiple episodes of acute pancreatitis, multiple hospitalization, multiple imaging studies, including sonogram, CT scan, and MRI. At least 4 to 5 hospitalization per year. The first time he was diagnosed acute pancreatitis at the age of 16 back in 2013. So in between the attack, he does not have significant pain except abdominal discomfort and gas, abdominal gas, which was managed with just antispasmodic, no narcotics. However, the disease was progressed. Subsequently, he was diagnosed chronic pancreatitis with some feature, including calcification, ductal dilatation, parenchymal atrophy with the CT scan in 2021, which is last year at the age of 23. So, meantime, he was seen by multiple gastroenterologists, and then lastly by hepatobiliary surgeon. So he does not have any family history of pancreatitis or pancreatic cancer. Symptom-wise, obviously his weight fluctuates. Once he have attack, he cannot eat. Otherwise, no diarrhea, no steatorrhea. Obviously, he does not drink. He does not smoke. So then, due to persistent symptom and recurrent hospitalization and significant findings with imaging, he was evaluated by surgeon.
I'm sorry to interrupt. Khurshid, do you have any slides been seen here? I mean, I don't see the slides.
I put share. Anybody can see? Other audience can see or no?
Slide is we seen the slide. But there is some scratch mark over the slide.
Oh, somebody did that. I don't know. One of somebody by mistake did that.
Okay.
Yeah, it
Uh,
happens. Yeah, the
that,
squares.
it's beginning. Somebody by mistake did that, not by me.
Okay. Okay.
It
Just
happens
remember
sometimes.
the
Fine,
slide.
we are okay with it.
Yeah, those marking is not by me. It's somehow.
Oh, sorry to
Okay.
interrupt.
Continue,
Okay.
please.
So, Atik bhai, can you see now?
Yeah, I can see now. Thank you. Thank you.
Okay.
I think
Okay.
you can
So,
enlarge the screen. I think you can
enlarge
expand.
this. Expand is X. No. Let me see. Is it better now?
Previous one,
Yes, little bit.
Little bit. Oh, well, let me see.
but previous one was good. Okay, no problem.
Oh, okay, no problem. So he underwent surgical intervention, which is a lateral pancreatic hysterectomy. We'll talk about more in next slide. So postoperatively, he's doing okay. That is, he doesn't require any pain management with opioid, which is a very good news. Then, based on this history, gentlemen, what is the etiology of chronic pancreatitis in this young gentleman? What is there any molecular genetic testing done? Any risk of pancreatic cancer on him? A risk of diabetes? Any recurrence of pain? What is the second option in future if needed as a rescue surgical procedure? So tonight we'll find all the answer with further discussion. So we'll talk a little bit about chronic pancreatitis. Everybody knows that. I'll not spend too much of time with that. We'll spend more time with the management part. So we all know that it is a fibroinflammatory syndrome of pancreas, a level of persistent pathological response to parenchymal injury or stress. It is irreversible morphological change of the pancreas and destruction of the architecture. It is associated with permanent loss of exocrine and endocrine function. It can associated with further complication like biliary or duodenal obstruction, calcification, thrombosis, cirrhosis, and rarely pancreatic cancer. So what is the cause of chronic pancreatitis? Number one is long-term use of excessive alcohol. Is not true in our country, is mostly in Western countries, as we all know. And again, most importantly, the amount of drink and duration of the drink. Normally, 5 drinks per day for 10 to 15 years is very significant to cause chronic pancreatitis. So another risk factor, cigarette smoking. And also, there is a very interesting, actually, tropical chronic pancreatitis, which is happen in malnourished condition. It can be happening in Bangladesh, it's India, Indonesia, and some other country of the Africa. So we don't know exactly why, but one of the association is malnutrition. If anybody can share with me, is there any cases in Bangladesh we see regarding tropical chronic pancreatitis? Normally they have abundance of calcification. So other uncommon etiology can be chronic obstruction of the pancreatic duct by ampullary stenosis or neoplasm, pancreatic tumor, cirrhosis, pancreatic duct stand if it is sitting for longer period of the time. For example, if somebody have ERCP and a pancreatic stent was placed to prevent the ERCP-induced pancreatitis, but by any reason it was not removed for a year or so, then it can cause some chronic changes. So obviously, uncommon cause can be traumatic, inflammatory stricture of the pancreatic duct. Again, some other, I'll try to finish here quickly because we'll pay more attention on management part. So pancreatic diphysum, uncommon, and genetic hyperlipidemia or hypertriglyceridemia. Normally, it has to be more than 500. So again, uncommon cause, but can be missed if somebody has hyperparathyroidism. Make sure there is no adenoma. If suspected, make sure we can do sonogram of neck to rule out edema of the parathyroid. So again, uncommon cystic fibrosis, some hereditary disease. We talk more in next slide. So beside that, all the known causes, sometimes we don't know exactly why a patient has acute pancreatitis, which is known as idiopathic or occult acute pancreatitis. So for example, here, if somebody already had a US CT scan, MRI, did not show any biliary stone, but it can be also gallstone or sludges, which can be missed with a regular imaging study. Again, if somebody has a hypertriglyceridemia, can cause acute pancreatitis, we know that. Some other anomalies, sphincter dysfunction, extremely rare. And obviously, we know that genetic and hereditary cause related with the mutation. We'll talk more. So I'll spend a few minutes with the genetic or hereditary cause of pancreatitis, as our case might be related with that. So what are the mutation can cause chronic pancreatitis? We know that CFTR, SPINK1, chymotrypsinogen C, PRSS1. So normally 1% of chronic pancreatitis associated with the mutation of PRSS1. This is an autosomal dominant disease. 40% occurrence of pancreatic cancer by the age of 60 is very important to know, and counseling for the patient and the family, and also to confirm the genetic testing. So how it happened, if somebody has mutation of any of those, it causes autotrypsin activation. So we can see the normal structure of the pancreas. This is the acinar cell. So if there is a mutation, in no reason, it can cause activation and repeat the cycle. So again, how confirm the diagnosis? We have to do the molecular testing, which I'm not sure is available in Bangladesh or not, but it might be available in future. It used to be very expensive. They check complete genome. It was first time done in 2003. Now we can check it in US. Is widely available actually, and relatively cheaper, less than $1,000. If you order that, they check complete genome. That means it will be checked entire DNA and rule out all kind of genetic abnormalities. So autoimmune pancreatitis can cause also chronic pancreatitis. So I'll try to finish very briefly. Especially, it's very important to know type 1 and type 2 in terms of management standpoint. If it is type 1, normally it happens at the male predominant at the age more than 60. There is some symptom of jaundice, fatigue, weight loss. And the most importantly, in this case, we always check serum IgG4 to rule out autoimmune pancreatitis. But if it is type 1, only that case, IgG4 will be elevated. If it's type 2, it will be normal. And also, there is systemic involvement with type 1 autoimmune pancreatitis, like it can involve biliary tree, salivary gland, lymph node, and retroperitoneal area. However, it's type 2, it's happen young people around 50. They can have concurrent inflammatory bowel disease, abdominal pain. Their IgG4 is normal, and histology is completely different. You can see that type 1 histology changes is lymphocytoplasmic and IgG4 positive staining. If you do histology on biopsy on type 2, the change will be called gel, granulocytic epithelial lesion. So the other good thing is for type 2, there is recurrence rate is actually low, and there is no response with steroid. So those are the changes we see in chronic pancreatitis. We all know that there is atrophy, calcification, fibrosis, and inflammation. Again, how to diagnose? So symptom-wise, we know pain is the most common symptom This pain can be very non-specific, especially if it is a chronic pancreatitis, can be epigastric, can be dull pain, can be constant, can be intermittent, occasionally radiate to the left upper quadrant, not the back. It radiate to the back, it happens if there is acute pancreatitis, not usually with the chronic pancreatitis. So we know that patient like that, sometimes partially relieved with the sitting or bending forward. Patient can tell that it worsened with ingestion of the food or alcohol. Can be associated with occasional nausea, vomiting, weight loss. It can be multifactorial. Patient cannot eat due to pain, and also associated with exocrine insufficiency if advanced cases. So other symptom, steatorrhea, not seen in early disease. If advanced disease, then we can see steatorrhea up to 30 to 50% of the patient. As you see, you don't see the steatorrhea unless pancreas burnout on up to 90% of the parenchymal cell. So diabetes can be happen up to 40% of the patient. It called type 3C diabetes. So we have type 1, type 2, and this one is type 3C. So there's a characteristic of this kind of diabetes. It happen normally a wide range of hypo or hyper glycemia. And it is not associated with diabetic ketoacidosis, not associated with nephropathy, but it can be associated with other complications, right? Retinopathy or neuropathy. So again, in advanced cases, rarely patient can present with pancreatic ascites or pleural effusion if there is a rupture of the pancreatic duct. For the diagnostic tool, obviously imaging, you can see in advanced cases calcification even with normal simple abdominal X-ray. And then most of the patient, we do CT scan. You can see typical findings, calcification, dilated duct, irregularities throughout the pancreatic duct, and pancreatic atrophy. So here you can see very clearly calcification, dilated pancreatic duct. So MRCP, so we have to know that when we should order MRI, when we can order MRCP. So MRCP, if you want to see pancreatic duct, biliary duct, then MRCP is the best test to order. And only other good thing is for MRCP, you don't need contrast. You don't need to think about the allergy of the contrast. But this is not the best to see the entire pancreas. So for the duct, MRCP is still a very good test. So again, if you have any doubt with the diagnosis, especially if this is a indeterminate or very early, then US is the best test to confirm the diagnosis of chronic pancreatitis. There is certain criteria. If 5 or more out of 9, then it is diagnostic. So you can see here with the US picture, duct has been dilated, and also you can see very clearly 2 upper and lower margin with hyper echoic line here. And also there is some echogenic strain here and there in the pancreatic parenchyma. So those are the feature with the US. ERCP not anymore, is more invasive, a lot of risk. Nobody does ERCP to confirm the diagnosis of chronic pancreatitis, but it can be done for therapeutic purpose, and you can see all the typical feature of chronic pancreatitis. What are the other tests we can do to confirm the chronic pancreatitis? We can do fecal elastase, but we have to be very, very careful with the interpretation. So only we can see positive fecal elastase if there is a moderate to severe steatorrhea, but there's a lot of false positive, false negative. That means this test is associated with low sensitivity and specificity. So still, we also can check fecal fat. It should be high, and we also can check serum trypsinogen. It should be low. There's other test, I don't know is available in Bangladesh, but we don't do in the US. but it is popular in Europe, which is a triglyceride blood test. So beside, we have to see what are the other differential for pancreatic exocrine insufficiency, endocrine insufficiency and exocrine insufficiency. So the other disease related to pancreatic insufficiency, like celiac disease. Why is that? As we know that celiac disease involves the proximal small bowel, and then it can cause lack of secretion of the CCK and secretin. Subsequently, it can decrease the secretion from pancreas as well. And also acquired cause, if somebody has a gastrojejunostomy, they can have also pancreatic insufficiency. So now we'll spend more time here. This is the most important slide tonight. What is the mechanism or etiology of the pain in chronic pancreatitis? So we can see that in the picture. So it is happened due to ductal hypertension, due to stricture and stone, pancreatic parenchymal hypertension due to fibrosis and calcification. Some other etiology also local oxidative stress, inflammation. Also, it can associated with complication like a pseudocyst, biliary and gastroduodenal obstruction. Rarely patient develop cancer, then we can see other feature as well. Again, we'll continue with the mechanism and etiology of the pain in chronic pancreatitis. So this is, again, this is very, very important to understand. And this is actually latest information we have in terms of chronic pancreatitis, how the pain is the #1 symptom of chronic pancreatitis and why it is persistent or constant pain in case of chronic pancreatitis. So it involves with the peripheral and central sensitization, so which is a neuropathic pancreatic pain. So how it started, I'll show you in next slide. You can see here. So it started from intrapancreatic nerve, and then it involved central nervous system, including efferent nerves, dorsal root ganglia, posterior column, ascending tract, thalamus, sensory cortex, and descending inhibited pain pathway. So this is very, very important to understand why a patient can have persistent pain even after surgery. So, and again, it's most important to know what other the causes can cause accelerate this pain. So if this kind of patient always they have pain and come to ER, come to the hospital, come to the office, and we like to give narcotics. So that's a big mistake. If you give narcotics, this kind of scenario, what's going to happen, this pathway will be accelerated. So we know that it can cause opioid-induced hyperalgesia that accentuate the neuropathic pain process. So then what's going to happen, patient will have constant pain. At the same time, patient may develop narcotic bowel syndrome as well. So normally that kind of changes, you don't see overnight, you don't see in a month or weeks. It happened 5 years after the diagnosis of chronic pancreatitis. But it's very important to understand. So you can see that how it started, as I mentioned, that from pancreas is sustained activation of the pain receptor in the pancreas. It goes to central nervous system, and you can see it fire back here, causes persistent inflammation. So that means if you even do the surgery or remove the pancreas, this pathway will never stop. So this is the latest information about the pathophysiology of the chronic pancreatitis, and management standpoint is very important. So again, if we know this kind of patient already on opioids diagnosed a couple of years ago, our goal is try to taper off narcotics. If needed, we can involve the specialist, like a pain management specialist, and also make sure there is no other etiology that can cause pain of this kind of patient. So again, #1 is abstinence from alcohol and smoking. So that's not a big problem in our country because not too many people drink alcohol, but smoking might be a problem. So why this is so important? You can see with this cartoon, alcohol, smoking, ductal tissue dilatation, ductal hypertension, and auto activation, which happen with the genetic mutation, inflammation, all causing pancreatic stellate cell activation. So that is eventually causes fibrosis, and that also causes activation of free radical. So this is the difference here. We know that we need the antioxidant to stop this pathway. So I'll talk more in next few slides about this management plan. So here's one of my patient, 58-year-old male, history of hypertension, chronic pancreatitis with complication, cirrhosis, alcohol use disorder, came to the ER with the complaint of severe abdominal pain, vomiting for 1 day. So he still smoked 1 pack of cigarette per day. He tried to be sober, tried to stop alcohol, but he relapsed. So that means he stopped drinking again. He drank 3 to 4 beer a few days prior to admission. So you can see that imaging study is a markedly dilated pancreatic duct here, right here. So this is a photosystemic, and then this is the pancreatic duct. So it's 2020, and then this is the most recent one after admission last month. So you can see further dilation of the PD, pancreatic duct. So again, why he admitted? Because of alcohol. So one more picture here, you can see he also has large size calcification right here. Also, you can see another picture right here. There is a calcification. Okay, so we'll continue. One other patient, my clinic patient, she's 50-year-old female, chronic pancreatitis, diagnosed a couple of years ago due to alcohol, weight loss, pancreatic cyst, chronic anemia. So she came to clinic. Her main concern was weight loss. So then what happened, I tried to counsel, patient stopped drinking, and actually she's so far sober since 2018, and then still smoking, but she's trying to stop. So with these two maneuver, no drinking, and try to stop smoking, currently she doesn't have any abdominal pain. And with the nutritional management, you can see her weight trend. She actually gaining weight with alcohol abstinence, smoking cessation, and the wean of narcotics, and then nutritional support. So again, main patient come to us mostly due to pain, some other complication too. So how to manage? We again, as I mentioned to you, everybody, we always try to avoid the opioids, but we can use NSAIDs, tramadol, temporarily, like 1 to 2 weeks, then as needed. Obviously, patient admitted in the hospital, we have to use a short course of narcotics if there is severe pain. Now, so also we can use pancreatic enzyme. It may help to decrease some pain, but not a lot. So if we need to use pancreatic enzyme to relieve some pain, it has to be uncoated. And if we use uncoated pancreatic enzyme, we have to use concurrently PPI. So how it works? This uncoated pancreatic enzyme block the CCK, eventually block the secretion from the pancreas. Again, most importantly, patient need antioxidant, as we show in the previous slide, to prevent the oxidative injury and eventually reduce the pain. Also, we can try gabapentin. We can try gabapentin has a lot of side effect, but I prefer to use pregabalin 75 milligram. There is a study done that shows if we start 75 to 300 milligram BID for 3 weeks, it decreases the pain severity. We can also try with the cognitive behavioral therapy, some other intervention that not help much. So at this point, what is our next plan? Because this kind of patient already diagnosed 4 to 5 years ago, they have chronic pain, they have persistent pain. So at this point, we should involve interventional endoscopist and the hepatobiliary surgeon. So what are the antioxidant? I know in Bangladesh, we have antioxidant available, but I'm not sure they have all 5 component in the antioxidant bottle. So this bottle actually I designed. If it is available, that's fantastic. If in Bangladesh is not available, we can ask a pharmaceutical company, please make this antioxidant for our patient who have chronic pancreatitis and chronic pain. So this has to have selenium, 600 microgram, ascorbic acid, vitamin A, E, and most importantly, methionine. That methionine 2 gram, there's a trial in actually done in India. They gave this 6 months of therapy, and they see that patient did very well. Pain severity is significantly decreased. So again, at this point, we have to involve interventional endoscopist and surgeon. So when is the best time or when we have to do that? If we see that disease duration 4 to 5 years already, patient is narcotics dependent, and there is a central and peripheral sensitization of the nervous system. So why you need to do that? We need to long-term pain control and the prevent complication. So those are the procedure done by mostly advanced endoscopists. If there is a stone, we can break it with the extracorporeal shockwave lithotripsy. It should be available. I am not sure, but in US, only few center this machine is available to break the stone. I don't know is available in Bangladesh or not. You can share after this discussion. So, but it has to be small stone, like a 5 millimeter or less, to have the extracorporeal shockwave lithotripsy. Also, we can do lateral lithotripsy. However, if the stone is bigger, like a more than 5 millimeter, then we have to do the extracorporeal shockwave lithotripsy as well as ERCP with PD stent placement. It has to be at least 10 French, and we have to place it for at least 1 year. If there is pseudocyst, it needs to be drained. Also, if there is other complication like a biliary sphincterotomy, you have to do with multiple stent placement or fully covered self-expanding stent for bile duct entrapment. And we have to leave this stent for 1 year. So if there is further complication like a duodenal stricture, we can dilate with a balloon. Also, if there is a non-dilated pancreatic duct, advanced endoscopist can do celiac plexus block. However, there is some limitation. It works only for 6 months to 1 year, and after that, a patient can have again symptom. So, surgical therapy. What is the aim of the surgical therapy? Drainage of the obstructed pancreatic bile duct, resection of the affected portion of the duct if needed, but choice of surgical procedure all depend on duct size, calcification, and the area of involvement. With this small cartoon, you can see that management standpoint, if it is non-dilated duct, mostly we'll try to manage the medical therapy or endoscopic intervention like a ganglionic block. If it is dilated duct, then our choice is extracorporeal shock therapy, endotherapy, or surgical intervention. So here is the surgical intervention, lateral pancreatic duodenostomy, which was done with our patient by Dr. Saif. We'll hear from him after this presentation. So when we can choose about this procedure, obviously this kind of patient diagnosed chronic pancreatitis 4 to 5 years ago, they are narcotics dependent, and pancreatic duct has to be dilated more than 6 to 7 millimeter. So what happened after the surgery? So a very good result, improvement of pain, at least 70 to 80% of the patient now if pain assessed at 6 months after surgery. However, you can see as days goes down the road, the pain improvement can be decreased to 50 to 60% in 3 to 5 years. So what exactly surgeon is doing here, you can see duct is very dilated. So they explore here, they explore proximal and mid pancreatic duct, and here side-to-side anastomosis with jejunum. So other procedure can be done is called Fry's procedure or modified Whipple procedure. If there's calcification or fibrotic tissue involved head of the pancreas, pancreatic duct is non-dilated, and there is a procedure is called duodenum preserving pancreatic head resection, which is better than Whipple. But at this point, the best surgery is Fry's, which is often done in US. Again, what is the other option? If, as I mentioned, the surgery depend on area of the involvement. If tail of the pancreas is involved, then surgeon can do distal pancreatectomy. If there is a pancreatitis due to, it's called Gros pancreatitis, then procedure of choice is Whipple. The other one is total pancreatectomy with intraportal islets autotransplantation, but is not commonly done. It depends on local expertise. There is some limitation as well, but it helps to prevent or delay the diabetes, as there is a transplant of the beta cell prior to surgery. It decreases the pain 92% of the cases, but there is a possibility of the graft failure in 1 year by 12.5%. So normally patient with a genetic predisposing factor, genetic mutation, young patient, for those patients, this surgery done often. As I mentioned, that this procedure normally done to prevent or delay the diabetes. However, at the age of 3 after surgery, only 25% of the patient can have diabetes. So now, which one should be done? There is a debate. It should be managed by endoscopic therapy by advanced GI, or it should be taken over by hepatobiliary surgeon. So according to randomized trial, surgical procedure actually superior over endoscopic therapy in terms of duration of pain relief. Also, if patient have a surgical procedure, no need of repeat intervention. And end of the day is mostly depends on patient preference. Most of the patient to like to have endoscopy procedure before they go for surgery. So if patient have, go back to the medical management, I want to discuss a little bit again. So patient needs pancreatic enzyme. If there is a cysturia, make sure patient is getting right dose with the right timing. It should be 24,000 to 36,000 lipase unit with meal. And also, if patient needs 2 pill, one before meal and another one in between food. Make sure patient is getting enough protein supplement. Still, there's a problem with the fat then we can add medium chain triglyceride. So this kind of patient is always risk for osteopenia and osteoporosis. Now we can order DEXA to rule out this condition. The patient should be on multivitamin. Also, patient should be on B12. Also, we have to keep in mind chronic pancreatitis can be associated with pancreatic cancer. When we suspect that, if we see there is a change of pain pattern, there's weight loss, they're not responsive to enzyme replacement. Also, there is obstruction, new onset of depression. There is a new diagnosis of thrombosis and worsening glucose intolerance or diabetes. Then we should think about chronic pancreatitis with cancer. So this is a picture here. So again, I'm back to the discussion when we should consider for genetic testing. If somebody have positive family history, pediatric patient, persistent disease, even all kind of intervention that we discussed. Young patient. So what are the commonest genetic mutation? PRSS1, SPINK1, CF, TR, CT, RC. So before I finish, I'll discuss two questions for the audience. This is a 56-year-old male, alcohol-related chronic calcific pancreatitis, present with a chronic abdominal pain. His pain regimen includes oxycodone 5 mg orally 3 times daily and gabapentin. On this regimen, he report 5 to 6 out of 10 upper abdominal pain. Pain is frequently postprandial and occasionally associated with nausea and emesis. He has been admitted to the hospital for pain control at least twice in the year. He has quit alcohol, but continue to smoke half pack of cigarette daily. He has no other significant medical problem. CT scan is performed and revealed calcification in the head of the pancreas with dilation of upstream pancreatic duct. Up to 10 millimeter, we can see here is very dilated. ERCP with lithotripsy is performed, which only temporary relief with pain. What is your next recommendation for best option for duct decompression and pain control? So again, it looks like it is a chronic problem and long-standing pain. So if you go number one, it will not help much because it's temporary relief, and patient already have ERCP with lithotripsy, did not help much. So next step is surgical duct decompression. So then another most important things we need to know, and we need to recommend our patient and family. A lot of patients ask if somebody diagnosed pancreatic cancer in the family, they may ask, should we do any kind of testing, CT scan, or US, ERCP, any kind of testing? The answer is not everybody need pancreatic cancer screening, only particularly patient. So this is a question here. If somebody has chronic pancreatitis, family history of the PTEN mutation, particularly relative with pancreatic cancer less than 60 years, multiple cancer syndrome. So who needs pancreatic cancer screening? So we know that all of the patients here, they are at risk for pancreatic cancer, but the highest risk here, Peutz-Jeghers syndrome, if somebody diagnosed with this condition, he should have screening for pancreatic cancer with CT scan with pancreatic protocol. So that is very important for the counseling patient and family. So who are the other patients may need screening to rule out pancreatic cancer? So beside Peutz-Jeghers syndrome, some other consensus for the pancreatic cancer is screening all carrier with germline mutation, CDKN2A. If somebody carrier of germline mutation of BRCA1, BRCA2, PALB2, ATM, MLH1, MSH2, or MSH6 gene mutation with at least one affected first degree blood relative and individual who at least have one first degree relative with pancreatic cancer. Also, another family member has pancreatic cancer. So those kind of patients should have screening. So all of the other patients, although they're at risk, there is no recommendation for pancreatic cancer screening. Sorry for that, I have just cold, so I have some hoarseness. So any question we can discuss? I'll open the forum now for discussion. Any question, especially I'd like to hear from our distinguished panelist, our renowned surgeon.
Thank you so much. Before starting my panel discussion, I would like to see the third or fourth slide. There is some your query, third or fourth slide. You have some query.
Here?
Post-surgical.
Post-surgery, like your specialty. Let me see.
No, third or fourth slide, initial from the very beginning.
Third or
Question about third or fourth slide. You have some
okay.
You have some
Here?
question. No.
Oh, in the question.
Yeah.
Here.
It's okay. So should I start, Dr. Atik Bhai?
I think Atik Bhai maybe still driving.
No, thank you. Thank you. Can you guys,
should I start?
can you hear me?
Yes.
Please.
Okay. Thank you so much, Dr. Atik Bhai, for inviting me this webinar. It is, I also thank the thank you. Dr. Atik Bhai is my senior in Chittagong Medical College. From the very beginning, he was very good organizer. I also like to thank Dr. Mohammad Khurshid Alam Majumdar for his very good and elaborate discussion about the chronic pancreatitis and pathology, etiology, pathology, and also discuss more about the molecular level and the management. Actually, I would like to start from the end about the management. Start from the management. For chronic pancreatitis, actually, there is no debate between the surgeon and physician about the management. Management is clear-cut regarding pancreatitis. First, it should be conservative. Then we can try, according to the case scenario, according to the case basis, we can try the endoscopic procedure. If it is success, then there is nothing about the other treatment. But surgical treatment only indicated when the all procedures is failed. That means conservative treatment is failed and endoscopic procedures is failed. Then we should go through the surgical procedure. So regarding the treatment protocol, it is not there is no debate which one is superior. Surgery is the last resort. And the problem is nowadays after surgery, some patients come to us with the previous episode of problem, previous problem. It is now the big problem. So then we are in problem whether we should go further surgery. There is no, actually there is a very limited option for further surgery. And whether we should go celiac plexus block or other supportive conservative treatment, like already Dr. Khurshid Alam Majumdar already discussed about the antioxidant therapy, pregabalin, neuropathic block, and alcohol injection, and some there is acupuncture therapy, which one it is also the last resort after surgery. So, and we managed a lot of patients in pancreatitis in our country, lot of patients. But in the book, it is written in the book, if the surgical treatment, some patients will get benefit. It is 1/3 patients will get benefit. 1/3 patients will get some benefit, and 1/3 patients will get no benefit. It is in the written. But in our practical experience, nowadays, we do the surgery and very less, it is maximum up to maximum 10% patients come back to us with the previous clinical feature and previous problem. Very less. I don't know. It may be due to the surgical skillness, developed surgical skillness, or different type of surgery. There are a lot of surgical procedures in the chronic pancreatitis. I am not. The physicians will discuss about the conservative management. We also sometimes use the conservative management. I would like to discuss about some surgical management. This the topics is actually the very good topics. Management of chronic pancreatitis in multidisciplinary approach. Definitely, it should be multidisciplinary approach. First, gastroenterologist or medicine doctor, then the surgeon, and after there is a analysis department. They sometimes have take over the patients to control the pain or pain. And this is the important thing. But in our experience, actually, when a conservative treatment is failed, then we take over the patients for surgical treatment, and endoscopy procedure also failed. And the thing is that when the endoscopic procedure or other procedure like lithotripsy, laser lithotripsy, this procedure it requires a highly skilled and lithotripsy. Sometimes it is not for a very small stone. ESW, it is for very small stone, and contact lithotripsy, it is also the very high skill procedure. And the problem is that when the lithotripsy or endoscopic procedure done, they have to put the stent for the several months. It should be placed only for 6 months. If it is more than 6 months, it is defragmented, and again it created the problem in the pancreatitis, and patients come to me. I have a lot of patients who have endoscopically or ERCP procedure. Endoscopically, they did the treatment. I have more than 10 patients who have done ERCP and done the ERCP stone removal and give the stent. It is one patient, he has 8 times. It is done by our renowned gastroenterologist in Bangladesh. 8 times ERCP. I have record. ERCP by expert gastroenterologist. But patients come to me. I'm not. I just for the record, you can say it is. I do the surgery. Patients after the surgery, patients suffered 10 years, and several times they did the ERCP stent, ERCP stone removal, stenting, re-stenting, again stone removal, again stenting. After surgery, patients last 2 years, patient is very well. He has no complaint. And another very young girl is only 17 years. He also came with 5 times ERCP and stenting in our renowned endoscopist, and 5 times ERCP, but patients in not relieved. So I did surgery. Surgery is a different form. I did surgery, and patients for the last 3 years, she is also well. There is several example to me. So before giving a stent, it should be clear that whether a stent or ERCP procedure should be feasible for this patient or not. Here, ERCP only done, there is a very small stone less than 5 millimeter. It should be removed, and definitely stone clearance is very important. Sometimes our endoscopist put the stent and stone 1 or 2 stone removed, and they did the procedure. But it is not the. It is actually it is not suitable for the patients, and the patients suffer more and more. So my suggestion: there is a lot of surgical procedure for chronic pancreatitis, Dr. Hasim Rabbi will agree with me. There are a lot of surgical procedures. Our main aim should that actually the chronic pancreatitis etiology is a lot, and the main thing is there is a doctor in our scenario. We got most of the patients is a very large stone, multiple stone, and it is not possible to remove endoscopically. So we did. Our aim should be remove all the stone and pancreaticojejunostomy. It is any form. There are different forms of pancreaticojejunostomy, like in phase 2, lateral pancreaticojejunostomy, Beger's procedure, Fraisse procedure, distal pancreatectomy, Duval procedure, and Barn procedure, and finally sometimes the Whipple's procedure also have to put for the patients. And total pancreatectomy is the last resort, and there is definitely some controversy. Total pancreatectomy and islet cell transplantation. Actually, total pancreatectomy, after total pancreatectomy, patient develop exocrine and endocrine insufficiency permanently. But it should be definitely, it should come in a debate whether the total pancreatectomy and islet transplantation is feasible for this patient, because patient after total pancreatectomy, patient can exocrine supplement and endocrine treatment. That means diabetic treatment, patient can go a lifelong through the life. But after transplantation, patients need a immunosuppression for lifelong. That should be debate whether which one is superior or not. I am not. It is matter of actually the researcher. They will decide which one is better. So regarding the etiology, in the first regarding the etiology in our country, we have a lot of patients. Most of the patients have no etiology. Most of the patients. So you think it is in our Southeast Asia, it is maybe the tropical pancreatitis or something hereditary pancreatitis. But my experience, a familial pancreatitis is a very uncommon here, because most of the patients come to us as single, not family member. All the other family member come with the acute chronic pancreatitis, and that is very rare. I have only seen in my through surgical life only one of the family, that 2 family member come to me with chronic pancreatitis. So surgery is only in when there is a sufficient duct dilatation. If there is a small stone, or there is sometimes diagnosis is actually, the diagnosis is clear cut. Pancreatitis patient diagnosis is clear cut, history, examination, and some investigation. Examination is nothing. History is important. There is a pain and exocrine insufficiency, endocrine insufficiency, and clinical imaging. Imaging, that means the X-ray, CT scan, and finally the if required, there is a MRCP. MRCP to see the duct condition, duct dilatation, duct anatomy. After seeing this image, we can easily plan which surgery we can do. But for the surgery, surgeon should take care to try to remove all the stones, and after removing the stones, they have to do the pancreaticojejunostomy. Stone clearance is important for the future management. If the stone clearance is 100%, then patients will get the benefit. If there is a stone clearance is not fully, then patients will come back again with the pancreatitis. Most of the patients. It is not only related to the decompression. It is also stone also in the parenchyma. So before my suggestion, before doing the surgery, try to identify the etiology. Sometimes etiology is related to the stenosis to the ampulla, stenosis pancreatic duct or ampulla. It is the main reason of pancreatitis, and sometimes there is some other anomaly like annular pancreas or pancreatic divisum. It is associated with. So before doing the operations, definitely try to identify the etiology. And the presenter, one case, 50 years old alcoholic male with chronic abdominal pain. Is repeated at hospital admission. But before doing any surgery, patients should definitely remove the etiological cause. Patient is alcoholic, smoker, and CT scan, there is a dark dilatation calcification, definitely it triggers the surgery. But before the surgery, we should have to abstinence from the etiological cause, like he should stop the alcohol and also stop the smoking. So it is definitely alcohol should he should stop. Otherwise, any surgery he can do a pancreatitis precipitate, and surgical patients blame on the surgeon, nothing do. So in short, I have to do, I can say it is a multidisciplinary approach. First, try to our conservative treatment. Secondly, with endoscopically or minimal invasive procedure. And finally, if there is all are failed, patient symptom is more and continuous symptoms, continuous pain, patient's lifestyle is hampered. So we should have to go for surgical procedure. And after surgery, when after surgery, patients come back depends on the surgeon's experience and surgeon's surgical procedure. If the surgery is perfect, very less amount of patients come to us. It is, although it is written in the book, 66% will come back with some pain or more previous same pain. But in our experience, there is a less patients come to if there is surgery, stone clearance is better. So I can easily recommend surgery if there is a enough dark dilatation, or we should wait for the dark dilatation. Ultimately, it will dilate once upon a time. Then we will do the surgery. So in short, it is my opinion. Thank you so much again. And if there is any question, I will panel from the audience side, we can answer about the surgical treatment. Thank you so much, Atik bhai.
Thank you, Saif. You mentioned it very right way, that it is a multidisciplinary approach, and every single case differ from case to case. Chronic pancreatitis is clearly a clinical diagnosis. A lot of tool now we have, endoscopic ultrasonogram making a big difference. Also, chronic pancreatitis, which has a higher tendency to turn to malignancy, especially pre-malignant condition, especially looking for the genetic mutation, SPINX1s, also endoscopic ultrasonograph, guided biopsy, looking for the pre-malignant cell. This helps us quite a bit to make the surgical decision, but largely what you say, that surgery is our last resort. And despite all those things, if I tell you the data from the center I work in Advent Health, we had a huge population of chronic pancreatitis. We medically manage them. Our interventional radiologist, interventional gastroenterologist do procedure on them, including the pain management and other aspects, determining the pre-malignant condition as well. A lot of complication related to the duct stricture, calcification of the duct. But I can tell you that if you have 100 patients with chronic pancreatitis, I would say moderate to severe symptoms, eventually maybe 10 to 15% go for surgery, and still it's a huge amount, and our surgeons are overwhelmed. So at this point, I have one question to ask, but before that, I would like to invite Dr. Hashim Rabbi about today's lectures. What is your comment?
Thank you. Before giving my comment, I want to thank Atik Bhai and the PHA for inviting me to be one of the panelists, and also want to congratulate Dr. Khurshid Alam, Khurshid Majumdar, for his excellent and light illuminating lecture. So the most of the things are covered by Dr. Saif Bhai and also Dr. Khurshid. I want to share our experience, the chronic pancreatitis, because I'm actually very much privileged to work in a hospital like Bardem, which is a tertiary care hospital. And also the Saif Bhai is also working in the most high volume center in our country. So the thing is that we are dealing with a lot of patients, and most of the patients usually come to us after failure of the medical management and also the endoscopic management. So my experience is that after dealing with a number of cases, the proper mapping of the disease is very much important. And what I usually do in my practice and what we follow in our hospital is that we map the disease according to the ductal changes and the parenchymal changes and the distribution of the stones. And if in our experience, most of the patients come to us with the head dominant disease and also involve the body of the pancreas, and very less number of patients used to come to us with calcification of the whole of the pancreas. So after our initial experience, we have actually published a lot of papers regarding treatment, surgical management of chronic pancreatitis. And after doing modified PAS2, and Partington Rochelle and lateral pancreatitis, we have seen that in our studies, only 67% patient has good pain control. Rest of the 33% doesn't have good pain control. And among the rest of the 33%, only 9% doesn't improve with any kind of surgery. So this 9 to 10%, there is no change of pain control, and also there is no quality of life. So we have revised and our methods of doing surgery. And after searching a lot of articles, we have seen that actually what Dr. Khurshid Alam has, Dr. Khurshid Mazumdar mentioned, that the Fraise procedure is one of the good procedures to do, because the damaged tissue should be removed to get rid of this pain. And after removing cause, there is ischemia, fibrosis, there's a cascade of reactions that causes chronic inflammatory change as well as the recurrent episodes of acute inflammation. So there is continuous release of cytokines and like bradykinins and other things, and that causes continuous pain. So modified Fraise procedure is a very good procedure to give us a pain control. We have published our 122 cases of Fraise procedure in IHPBA World Congress in 2018. But we have found that there is good pain control, but the patients are having nutritional, although they are in malnutrition, their nutritional nutrition is further aggravated after doing this Fraise procedure. They are having weight loss. Even after good pain control, they are having pancreatic diarrhea. So we have again thought that we should modify our procedure. And at that time, we actually came to a solution that we should remove mainly the disease part, not the whole of the pancreas or major disease part. So now we have seen that after doing head coring procedure, because in a good number of literatures and even the textbooks, we have seen that pancreatic head dominant chronic pancreatitis, pancreatic head is considered as the pacemaker of pain. So if we can remove the pancreatic head, leaving around 2 centimeters of pancreatic tissue along the C curvature of the duodenum, we can do the proper head coring procedure. We don't do the Vegas procedure. So we not doing the Burns procedure. So after doing Burns procedure along with celiac access block, we have seen that there is shifting of data with good number of pain control to 76%. And there is less number of patients complaining of without any pain control. So what we have found that combination of head coring procedure, actually the Burns procedure with celiac access block, that gives us a good pain control. So even after doing this kind of procedures, and with the Burns procedure, the number of patients having further aggravation of their malnutrition, and as well as pancreatic diarrhea. But we have seen that with the head coring procedures and the modified Fraise procedures, after removal of the diseased pancreatic tissue, around 33% of our patient has improved their glycemic status. So we have seen that after head coring procedures and the removal of the dead tissue from the dead or dying tissue from the pancreatic body and head region, there is improvement of the pain as well as the glycemic status. So now we are doing mostly the Burns procedure, and Actually, the thing is that we need gastroenterologist help, and especially the nutritionist help, and pain management specialist help for managing these patients. Because for the rest of the patients, we have to go for actually the interventional pain management. They usually do the celiac block, celiac axis neurolysis, and also the now in our hospital, Professor Kauser has started doing radiofrequency ablation of the celiac ganglion to control this kind of pains. So this is our experience, what I have shared, that as primarily a diabetic hospital, we have good number of cases, and we have actually a good number of publications involving the surgical management of the pancreatic, chronic pancreatitis. Thank you.
I have
Thank you, Rahul. Your data from your center and the publications you mentioned is pretty mirror what we do in our center. And even the surgical management, though we are shifting exactly the same way doing the burns procedures, but the mainstay is glycemic control post-surgical period, nutritional control, and pain management. This is the triangle we had to follow for any post-surgical management. Even with a phenomenal surgery, if we cannot achieve those, most of the patient doesn't do well, and the surgical outcome is not better. And that's what the role of a good center, where they have nutritional support, good pain management. And one thing, when we look at the data of head-to-head data of endoscopic ultrasonogram guided celiac plexus block frequency data is pretty much if the endoscopic ultrasonographer is a good good hand. But I'm very pleased to know that in your center somebody is doing that. In fact, the data is better with the interventional radiologist in most of the published paper. I have recent experience because I live in Orlando, and we have a lot of immigrants from Asia, and we have a good cohort of cases of tropical chronic calcific pancreatitis, and I have one Bangladeshi patient also who has that, and at least 25% of them has to go for surgery because it's very aggressive. And it happened mostly in the pediatric population. And the moment they turn 18, they become adult here. And the burden come to us, and we see them, a lot of them go for surgery. And I have seen that, the data which was told in the burn surgery, they are very successful. My question to both of you, is TCP is common in Bangladesh? And what kind of surgical procedure you recommend for those patients?
Can you repeat your question, please?
My question was tropical chronic calcific pancreatitis, which almost everyone leads to very severe chronic pancreatitis. What kind of surgery, first of all, is it very common in Bangladesh, and what kind of surgery you guys recommend them?
Actually, this group of patients also come to us with ductal calcification as well as the parenchymal calcification. We prefer doing modified Fraisse procedure with celiac axis block for these patients.
Yes, I can share with the Rabbi's talk. Actually, we assess the patients whether there is a sufficient duct dilatation. If there is a sufficient duct dilatation with stone, we definitely favor surgery. And most of the surgery in our country, in our settings, it is the lateral pancreatitis phase 2 operation or modified phase 2. Sometimes we, along with the phase 2, we can do the Fraisse procedure, that means head coring operations. It is most of the common. We have the problem actually when the stone in the uncinate process. So definitely it is a very big operation, and Beggar's procedure, head dissection surgery, duodenal preserving head dissection. It is actually the difficult operation, but sometimes we do the Whipple's procedure. It is instead of Beggar's procedure, Whipple's operation is easier than Whipple's procedure. So most of the times we prefer the Whipple's procedure, and it is better for the patients. And definitely, Dr. Atik Bhai I mentioned the tropical pancreatitis is common here. We actually don't identify any etiology. Most of the times there is a maybe it may be the childhood malnutrition or other cause. It is mostly present very small amount presents before their adolescent period, and most of the patients come to it after in the adult age, and male is common than female. So I have one question. So definitely for the tropical pancreatitis, if there is enough dilatation, we have to go for modified phase 2 or phase 2 procedure. And another, I have one question to the my presenter. Whether you are already Dr. Atik Bhai mentioned the pancreatic chronic pancreatitis is a common in Ohio state. Can you tell me what is the surgical result? Is it better or not, or it is the previous like in the book? It is 1/3 bed relief, 1/3 not, some amount. Whether the surgical result.
I think it's very similar, but it depends on the expertise. But overall, the result is very similar that you mentioned as per the study. But the problem here, the etiology is different than you see in Bangladesh. But because here the most etiology is a chronic alcohol use. So the pancreatitis from alcohol is little different from the tropical pancreatitis. Although it's very similar, but it can be a little different. The outcome-wise is very similar, but here they try, in the US, the commonest procedure done, the Fry's procedure, which is lateral pancreatectomy and the removal of the head part. That is the commonest one, but is very similar result. I feel even in Bangladesh, what you mentioned, I see the better result than US. Atik Bhai, do you agree?
I agree. My personal experience with the patient because we deal with majority with obviously chronic pancreatitis secondary to alcohol, and this patient, when they go for the surgery, because that's the last resort, and I would say the surgical result is obviously superior because we have no other options, to tell you the truth. But when we compare the overall outcome of alcohol-related chronic pancreatitis who's going for surgery versus TCP-related surgery, I find out that patients who are alcoholic and go for the surgery-related chronic pancreatitis, they do very well. In fact, TCP is one of the area they don't do very well. Their pain symptom is very hard to manage even after the surgery. They need the intervention from the interventional radiologist or pain management more often. I also see a very bad risk, glycemic. It's very difficult to do the glycemic control of those patients. So it's always remain a struggle for us. Chronic pancreatitis secondary to TCP who's going for surgery, post-surgical management. And that is one area I always kind of afraid to deal with these patients.
Hey, Atik Bhai, can you tell me what is the lifestyle after surgery in your country, in America? Whether the patient stop alcohol or not after surgery? They follow your advice?
The patient, it definitely varies with the patients. So the patients who has overall good nutritional status, but just going for the pain management or maintenance of the glycemic control, or going for because you find some pre-malignant condition and need a surgery with a chronic pancreatitis patient, their outcome is always very good. And these patients look like they get a completely new life and they're living with us forever. But the problem happens when the patients have severe steatorrhea, poor nutritional status to begin with, and we have no other options to going for the surgery. Their overall outcome of the surgery is not well. So pre-surgical, I think two indexes are very important we see. One is the overall nutritional status. And that's why we would like to beef up their nutritional status before even patient go for the surgery. Many times we delay the surgery until we get a favorable nutritional status, because that is a very important predeterminant factor for the success of the surgery. Another things we used to follow before, and radiologists help us a lot, to look at the overall total calcification score, and which they can do from a CAT scan. And that was helpful, but the ductal calcification score doesn't help much with the TCP. So that's what I would like to say.
I want to mention one important scenario. I need Dr. Kush advice that in good number of cases now we are facing that with head dominant chronic pancreatitis are presenting with features of obstructive jaundice. So in few of our cases, we have found that according to when the clinical is the Covercious law, according to the Covercious law, when the gallbladder is palpable, we consider it as the pancreatic malignancy and we did Whipple's procedure. But in few of our cases, we have found that even after going through it, we have found that these are actually not malignancy, these are benign. In two of our cases, we have found that these are tuberculosis. And I think Atik Bhai is coming this December to Chittagong, and Chittagong Medical College is presenting two of our cases there. They have found that these two cases were tuberculosis. So this is a new thing in our experience, and I need the question advice. What will you do in this kind of cases in your center?
I'd like to add some another two or three cases for the for webinar. It is actually sometimes we do not only the pancreatic decompression in the pancreatic duct. We also have to decompress the biliary tree also, because sometimes a stone in the head that or chronic pancreatitis and changes anatomy, or there is a strictures in the terminal CBD or ampulla. We have to decompress the biliary anatomy, biliary tree also, biliary bypass at the same time. So there is a double bypass. One is pancreatic bypass, another is biliary bypass. We practice these operations also in some patients. In which patients presents with jaundice. I mean, chronic pancreatitis present with jaundice. We have to also have to do the biliary bypass.
Yeah, so Dr. Rabi, I agree with you. There's some cases it can be benign even after surgery. Even I see in the Cleveland Clinic, there is surgery and it can be benign because they're very invasive, high risk procedure. But the problem is we always worry, if we see mass, we worried about the cancer. So that's why it happened here also, non-malignant, but we have to be a little bit of more vigilance. If we see mass in the head of the pancreas, make sure it is not autoimmune pancreatitis. If time allow, that means there is no other origin symptom, or no obstructive jaundice, or no ascending cholangitis, then this kind of scenario, we can give a try with the steroid, let's see what's the response, and repeat the imaging study. But again, it can happen, or if possible, repeat the US with FNA before for surgery. But again, this kind of patient is not only one problem. They have pancreatic mass. They have, Dr. Saib mentioned, they have stricture at the CBD, obstructive jaundice. So ended up with surgery, which is very, very invasive, and the robot surgery. But the other thing also consideration, the patient physical status, age of the patient. If young patient, we don't want to lose the patient. We don't want to have any metastasis of any pancreatic cancer. But again, it is a difficult situation to confirm. But good to know that we don't see any cases with the head of the pancreas mass due to TB here. But it's good to know, and learning standpoint. Actually, I learned today it can happen with the TB. Or TB can cause any kind of lesion mouth to rectum, to be honest.
I can also share one important thing.
I'm looking forward to see that those cases. I just want to mention that we'll be joining in Chittagong Medical College Teachers Association. They're doing a conference, international conference, and I see Professor Ershad. He's here. Is he still here in attending in this program? I'd like to get opinion if he's here. I saw Ershad was here a little bit time, but he's not here anymore.
So can I share one of our experience? One of our cardiologists from UK, his brother came to me with the same scenario, and we did a Whipple's procedure, and it came out to be an autoimmune pancreatitis, as Dr. Khurshid said. And postoperatively, after 3 months, patient presented to me with features of obstructive jaundice. And I have evaluated the patient, and I've actually thundered to see that I thought that my hepaticojejunostomy was strictured, but what interesting was that the patient later came to me with features of sclerosing cholangitis. So actually, the thing is that autoimmune pancreatitis and sclerosing cholangitis may happen. This is one of our case, and the patient is now doing better after doing the conservative management. And another important thing is that we actually follow Dr. Khurshid has mentioned that when we suspect a MUS lesion in the imaging while mapping a disease, we actually see for a malignancy, and we go accordingly. So one of the interesting findings, what we have found, that we have found good number of cases, and not actually good number, actually 17 cases of sarcomatoid carcinoma in our cases, where only we were able to do Whipple's in 2 patients out of those 17, and 2 distal pancreatectomy. And the rest of the pancreas, those MUS lesions with sarcomatoid carcinoma were inoperable. So actually what you have mentioned, that when we see a MUS lesion, we should be very much suspicious for evaluation of malignancy, whether it is in the head or in the body or into the tail region. So I actually I do agree with you and with your opinion that for any kind of MUS lesion, along with pancreatic calculi, we should suspect malignancy and go accordingly. Thank you.
Thank you, Atik Bhai. I have seen a lot of some resident from our university. They have joined. If you allow me, I asked them if there is any comment from our resident side, like Saidul Aman, Vineet. Do you have any Muslim Radifin? Do you have any comments from your side? If you allow, Dr. Atik Bhai.
Crash ahead on I-95S in half a mile.
Please feel free to ask any question. I think the discussion today was wonderful.
Am I audible?
Yes.
Yes. Okay. I am Dr. Shantanu Bishwas, consultant working in surgical gastroenterology, Sheikh Russell Gastroliver Institute and Hospital. So I want to ask 2 questions to Khurshid sir and Atik sir. Number 1 question is, what is your current practice in US on chronic pancreatitis, having pain in head dominant disease or in ductal disease, early surgery or in late surgery? What is your current practice in US?
That's a good question.
I think we should.
I mean, the standard of treatment of any patient with when it comes to the pain management, more and more we go for conservative treatment with a minimally invasive endoscopic procedure. Also, we did change the technique of endoscopic pain management quite a bit. Initially, we were just talking about celiac plexus block, but the method of the celiac plexus block also changed quite a bit, and then introduction of the new kind of needles with a different depth of penetration and also different angle of penetration to make it very different. So yes, still we try, as Dr. Saif and Dr. Rabi was telling, and Khurshid, that our first step of management is utilizing the non-surgical treatment, but minimally invasive procedure with our endoscopic procedures, and also utilize the obviously determination of the duct, determination of the calcification of the duct, interductal ultrasonogram. It helps us a lot to determine whether this patient should go for early surgical intervention than the late. Our data of the interductal endoscopic ultrasonogram for calcific pancreatitis, it really helps us to determine whether this patient will do well with our minimally invasive way to managing the pain versus making a determination to send this patient for early surgery. So I would still say that because of our techniques is improving and changing, we still prefer that, and if we cannot, then we go for the surgery.
We will be about 20 minutes.
Khurshid can add that with that.
I totally agree. So the area of advanced endoscopy is evolving. You see, last 10, 20 years is changed a lot, especially with the US and ERCP, you can do a lot. So, but this kind of patient is very important to see what's the quality of the life, and duct size also very important for the intervention. Because if there is no duct dilatation, you cannot do ERCP and surgery, obviously not an option also. So head involvement in this area is little difficult area as mentioned, because surgical option will be totally changed. But answer to your question is still we prefer conservative more than surgery, as this area is more evolving. But however, it all depends on the expertise, availability, patient choice, because this little difference practice than in Bangladesh. Here, you have to offer patient or detailed discussion, offer all the option, preference, insurance control. So a lot of other factor actually. So again, this area is evolving now, and intervention can do a lot of things before go for surgery. But if you are very honest, a lot of area actually early surgery is better instead of suffering the patient for 3 or 4 or 5 years and repeatedly keep doing the ERCP and standing. Some cases, to be honest, surgery is better. But you have to choose that particular cases and keep an eye, because this is the area, those are the patient very unlucky, I would say, because it needs a multidisciplinary approach. And not only pain, is overall, we have to be an advocate for the patient, nutrition, pain control, and what is the future plan. When we should initiate interventional radial endoscopies, when we should involve the surgery. I think sooner the better. Surgery should be on board little sooner, not like we finish everything and then to surgery. Just involve, keep in the same loop, then we can work.
As because with
You have to unmute.
Okay. So there is
Can
an
you
issue
repeat
of
that? We didn't hear
peripheral.
for the last 30 seconds.
Okay, okay. As there is an issue of peripheral sensitization of opioids, and an escape trial is going on now, as you know,
Mhm.
and a group of study have shown that early surgery is better, but there is
Right.
proponent group also. And okay, thank you for this answer. And I want to ask another question, if you allow me to ask.
Absolutely.
Okay. So I want to give you a scenario. The patient came to me a couple of days back. She was 50 years old lady with 4 years. She was suffering from diabetes mellitus for last 4 years. Actually, she went to an orthopedics consultant for low back pain. And when he was evaluating by doing some MRI, X-ray, and ultrasonogram, incidentally, he detected pancreatic stones. And somehow the patient came to me, and what I have seen that there is 14 millimeter duct dilatation in mid pancreatic duct. Okay, and there are some atrophy distally. But patient, when I asked the patient about pain, that was absolutely typically a low back pain, not the pain of chronic pancreatitis. So, in this scenario, what is your practice?
Okay. So sound like it's incidental findings, right?
Yes,
What's the
this is
stone
incidental
size?
finding.
Stone
Stone size is around 13 to 14 millimeter, and duct dilatation is around 14 millimeter.
Oh, big size. So
Yes,
big size.
and there are a bit atrophy of the pancreas. So my question is, patient has endocrine insufficiency, but there is clinically there is no exocrine insufficiency. Patient have no steatorrhea, but in this scenario, what is your strategy? Actually, should we manage conservatively, or what is your practice in US?
I think it's clearly we should try lithotripsy, and then
What is
clean
the
the
size?
duct.
What is the size of stone?
Size around 13 to
Size
14
is big.
millimeter.
And
So
what is the
big
duct
size.
And
dilatation?
it is, and these are in the these are scattered in the mid pancreatic duct and some are near the head region. And duct size is around 14 millimeter. So
if
it's
we
a very
allow-
big duct.
if we allow the-
It is not. It is very big size for
Okay.
endoscopic intervention because
Yes.
normally if it is 5 or less than 5, we can go
Yes.
easily do the lithotripsy or remove with the balloon with the endoscopy, ERCP with the PD intubation. But 30 millimeters is really big. So I mean, at this point, especially the asymptomatic, there are no other things going on. Advanced endoscopists may try, but it has to be two things available. The good lithotripsy and go with the ERCP and clean the duct as much as possible because it's very dilated duct, 14 millimeter, and put the stent for next 1 year. That's one option. The other option is just involve the surgeon in future, maybe ended up with the surgery, because here right now there is no symptom, right? And no
Okay,
symptom,
so
and then there is no other exocrine insufficiency. Diabetes is maybe she has diabetes like any other, like type 2, maybe not be pancreatic, not be related to pancreatitis.
okay, so what is your concern about this issue, that you want to improve the endocrine and exocrine insufficiency by doing intervention, or
Okay.
stop? You want to stop the pancreatic ductal hypertension, which causes back pressure and which is causing back pressure and
Further damage, right?
atrophy. So, are you concerned about the pancreatic acinar cell damage?
We are concerned, But
No,
in this case, I would say, because if you do surgery, it will be a big surgery, lateral pancreatectomy, right? That's the
no,
option,
no.
because
Yes, yes,
dilated.
yes, yes, yes.
It is dilated, or yeah, fuse too. So
But my
lateral
question
pancreatectomy,
is,
but I
okay.
understand your point. If you leave it alone, what's going to happen? Some point patient may come back with pain or exocrine or endocrine insufficiency, because it is persistently causing pressure and atrophy. But before you get advanced disease, then what you can do at this option? The
I
other
ask
option
something?
is
Should I
there
ask something?
any underlying causes that can causing chronic pancreatitis or further damage, especially for this particular patient? I don't see very known any risk factor, because looks like I presume she's not a smoker, obviously not alcoholic, right?
Yes, she's no, she's a 50 years old lady. She's a housewife.
Right. She's not
She's
no known risk factor
no known risk
to
factors.
modify. Or we
Yes,
can ask her, don't smoke or don't drink alcohol, nothing.
she don't smoke, not alcoholic, and she has no family history.
No family. So only the modifying things here is diabetes, right?
Yes.
Has to be control 100% controlled diabetes. But I think Dr. Saib, Dr. Atik, Dr. Rabbi, you can share in my mind.
I would add something, because we clearly this patient has one of the things evidence of acinar cell atrophy, and it is going to progress because of the the stone size is about 12 to 13 millimeter, he say, and then the duct is about 14 millimeter, isn't it? So
Yes.
I mean, still there is a good role of ERCP, and with the ERCP we can do some intervention, even though it's in the mid duct region. It can be done. It can be tried. I would try the endoscopic intervention first. See how it goes. Obviously, beside the diabetic control, the patient does not have significant pain or anything like that. It can certainly wait to send this patient for the surgery. But obviously, I would do, it will help the patient for further management of diabetes if we can get rid of that stone. Also, during the endoscopic procedure, would do a thorough ductal sonographic evaluation, and also do the ductal calcification score to make sure that what could be the future prediction of this patient.
Okay. Thank you.
Can I ask one question? The extracorporeal shock lithotripsy, is it available in Dhaka? Should be available, right?
Yeah, it's available.
The extracorporeal
Done for the
lithotripsy,
renal calculi.
right? Renal calculi,
Yeah.
but this one is different machine.
Yeah.
Available, right?
But
Because
the
what I'm trying to
radiologists
say,
nowadays are
I'm sure
doing-
I think very also very much
No,
aware about that. In the entire US, there is no machine.
The machine is there, because the similar machine you can use it for the ERCP as well. But I don't think so. Anybody is doing biliary extracorporeal procedures. I don't think so.
No, this is a totally separate machine, actually. I can share with you. In India, in Hyderabad, Asian Institute of Gastroenterology, Dr. Reddy, he's the chief there. He was telling in Orlando when I was there. So they do every day 15 cases. And this machine is especially dedicated to break the pancreatic stone, which is not available in the US, but in your place, they're trying to buy it, or they probably already bought it. So that's something is a very
So far,
good
I know that
addition.
one of the private institutions in Dhaka is having this machine. Probably
Yes.
this Shirajul Islam Medical College Hospital, they have the machine. But the
Yeah,
thing
that's a
is
dedicated
that,
machine only to
this is
break
not-
this stone.
Probably. Actually, I don't practice this thing. So I've seen few of the gastroenterologists used to refer patients there. But if I'm the physician of the Dr. Shantanu patient who's having a low back pain, I would have not gone for the treatment of the chronic pancreatitis at this moment. I would have taken the neurophysician's help to exclude his other causes of low back pain, because there are a lot of other causes of low back pain that would make due to neurological diseases or something. Because I have a bad experience in dealing similar kind of patients while the patient is having liver SOL for ovarian malignancy. Actually, the thing is that she came to me for liver resection for liver metastasis for ovarian malignancy, referred to me by an oncologist. After admitting her, she suddenly developed paresthesia of the lower limbs. And while evaluating this thing, I found that she was having metastasis in the bone too.
Good.
But actually, I should have gone for the evaluation earlier before admitting him. But the thing is that's why I was telling that before going for the management of the chronic pancreatitis, I would have taken the neurophysician's help to exclude her other causes of low back pain. If this has been excluded, I have followed the same protocols you guys have told, and I think surgical option for decompression and removal of the stone is a better option in the long run. Thank you.
Does anybody have any other question or comments?
I have one comment only for Shantanu's case. Actually, I agree with Dr. Atik Bhai and Rabbi. First, to exclude the low back pain. After excluding the low back pain, if there is a diabetic patient already endocrine insufficiency, then we should go for the either endoscopic procedure or surgical procedure. We have to that is enough dilated and size is more than 40 millimeter. So we should have to go for surgery. But before we can try the endoscopic procedure. It's my comments about the Shantanu's case.
Okay, thank you.
I think two hand raise. I think can they talk?
Yes, please.
Asfar,
I
Asfar,
don't
please.
see who raised hand, but
Assalamu alaikum.
uh,
I am Dr. Asfar, working as the resident in hepatobiliary surgery, BSMMU. Thank you, all the organizers who are behind this beautiful session, and all the panel of experts, especially two of our renowned hepatobiliary surgeons from Bangladesh. We have learned a lot, especially at this stage. This learning will help all of us to think in a different way to treat the cases of chronic pancreatitis. So we have learned the risk factors. We have learned the dietary modification, the role of antioxidant, the role of genetic mutations and other things, and different procedures, stepwise procedures from the medical management, surgical management, and the different exceptional scenarios like tuberculosis and other biliary obstructions and a lot more. So we hope in the future you will organize more programs so that we can be enriched with the experience of all of yours throughout the whole world. Thank you again.
Thank you.
Thank you very much. In fact, we are talking to Saif that we should do case-based presentation every month. The fellows can bring 2 cases and we can discuss with that. We can also use some faculty from here as well, both interventional gastroenterology as well as pancreatic biliary surgeon. In fact, I think that will be very good. Thank you for your nice comment. Does anybody have any other question or comment? In that case, Dr. Khurshid, please take over, and I would like to just
Okay.
thank.
Yes, sir. Sir, I am
Saeed,
Dr. Pradeep Kumar Mondal speaking.
Yes, please.
Sir,
Yes,
I am working in Bangamudhu Sheikh Mujib Medical University, Hepatobiliary Pancreatic Surgery Department, with our chairman, sir, Professor Mohsin Chaudhary, sir. And during working in this institute, we are facing a lot of chronic pancreatic patient. And we are trying to do many investigation, and during investigation, we found some patients are long time suffering pancreatitis, and they are also found exocrine and endocrine deficiency. That's why they are also found in low bone marrow, bone mineral density in our Bangladesh. I have found already 8 cases and 5 cases are bone mineral density low. That's why some patients suffering in pathological fracture like features like osteoporosis. So how many percentage of patients in your country, USA, suffering such type of illness?
You know, exocrine and endocrine pancreatic insufficiency here, the standard of care right at the beginning of the diagnosis of pancreatic insufficiency. And one of the major things, I see the difference of the management of chronic pancreatitis. Here, there's a lot of preventive steps we do, especially vitamin A, D, E, and K. Right at the diagnosis, we do DEXA scan of all the patients. So that's why we don't see that much complication related to the, metabolic complication related to the chronic pancreatitis. I think that is one of the most important things internists can do. A lot of preventative steps, especially related to the vitamin and mineral deficiency from the beginning. And I'm very glad that you guys mentioned it, because that is one of the mainstay of treatment, to be proactive rather than reactive. So that's a very good point.
Sir, if these patients come to you in digital X-ray and looking, you are that the patient is already has osteoporosis and possibility of pathological fracture, how many percentage in your country that may be prone to be pathological fracture, or medical treatment will not be sufficient in a fewer period? And do you in country have some such type of patients?
It depends from center to center and also where you practice. So obviously then I cannot tell the direct number, what the percentage, but in advanced center like us in Orlando, I can tell you that our percentage is very low with osteoporosis and pathological fracture in those patients. Very low. But I have seen a patient with osteoporosis. They incorporate the treatment with appropriate medications for osteoporosis, very early stage with incorporation of calcium. And vitamin, replacing the vitamins in a very early stages, we see those are standard of care. So if you don't do that, you basically fail on the management of the treatment. So electronic medical record automatically tell you, the doctor, did you fix these special points? Did you give these patients a vitamin replacement? Did you do the DEXA scan or not? So you can tell that it's a built-in process we have here. And that's why we can really save this patient in a very early stage, and that's why we do not see that much in a bigger centers.
Okay, sir. Thank you. So, do you face any patient of the sarcopenic patient in your country? And it is also available in our country. So that's why I am interested to know.
Sorry, I don't understand your question. What is it?
Sarcopenic patient, sarcopenia.
Sarcopenia.
Skeletal muscle wasting due to chronic pancreatitis, sir.
Very rarely. Very rarely.
Okay, sir. Thank you so much, sir. Thank you so much for giving to answer to us a lot of question. Thank you, sir.
No, I think doing some case presentation will really help. I think it will be very helpful in future, and I'm feeling more need for that. And once again, Rabbi and Saif, it's very nice
Red
to
light,
come
camera
today.
on.
And I would like to give the control to Khurshid again, Khurshid. But before I leave, I
Okay,
just want to
I
thank
think
everyone.
in planetary health, I was participating for last 2 years. This is the longest discussion, very interesting, very interactive, and learning wise, I also learn a lot. If you compare with US and in Bangladesh, all the participant, distinguished physician, I think you guys doing much better job, in some area even better. But as we know, we have some problem in terms of education, in terms of nutrition, and so busy everybody, and non-compliant issues. Otherwise, physician standpoint, you are delivering 100% or more than that, some area. No doubt, I like to thank again everybody. I think it's midnight in Bangladesh. For me, it's not a problem. It's only 2 p.m., but it's midnight. Again, thank you so much for everybody. We'll keep doing that, continue doing that, finding interesting topics or cases even. We'll keep in touch. Again, Dr. Rabbi, thank you so much. Dr. Saib Bhai, thank you so much. Is there any question? Otherwise, we'll stop.
No question. Thank you so much for a nice deliberation and nice webinar. And also thank you, Atik Bhai, for arranging such a webinar. And I agree with Dr. Atik Bhai. In future, he will arrange for our resident to arrange the case presentation in this webinar.
And
Thank
a
you.
award too. Case and who is presenting for them some award.
Yeah. Thank you. Thank you so much. Big hand for Atik Bhai for award.
Thank you very much.
Saib
everybody.
Bhai, now I recognize you. Now I can correlate 30 years ago that I saw you.
Thank you. Yes.
Okay, in main hostel.
Yeah. I was first
Okay.
in 6B.
Again, thank you so much, and also most welcome in US for travel, vacation,
Yeah.
or see any big institution.
Yes. I will come in January.
January. Okay. Why not in this? If you can move in February, there's a big convention in February in Atik Bhai's city.
Oh, I see.
In February.
Okay. Let's see.
Okay, but it's still fine. Again, if please keep in touch, we'll keep in touch. And most welcome to Cleveland as well. And thank you so much and good night.
Thank you.
Okay. Bye-bye. Thank you very much.
Thank you. Thank you so much for the wonderful session.
Thank you.